We are coming to you live from the site of the Triangulating on Health Equity Conference in San Juan, Puerto Rico. Our webinar tonight is entitled Best Practicing in Integrating Health Promotion, Primary Care, and Social Determinants to Improve Community Health Outcomes. Our featured webinar presenter is Dr. George Russ, the Director of the National Center for Primary Care at Morehouse School of Medicine. Now, just to share a little bit of background on Dr. Russ, he is a board-certified physician in both family practice and preventive medicine. He has spent the last 2 decades of his life teaching, doctoring, researching, and developing programs and research partnerships between Morehouse School of Medicine and community and migrant health clinics. An application for CME credit has been filed with the American Academy of Family Physicians, and this webinar has been pre-approved for 1 hour. Today's presentation will be divided into 2 sections with a brief intermission for questions after the first session. There also will be an extended question and answer session at the end. However, questions and or comments can be submitted throughout the presentation by simply typing them into the Q&A box and pushing submit. So with that said, ladies and gentlemen, let's welcome Dr. George Russ.
Well, thank you so much for letting me be here. And Sabrina, thank you for all of your wonderful introductions. We are here in San Juan, Puerto Rico, where we have sound effects of the ocean, and I think it's a peacock in the background. We are also engaged in a much deeper work in dialogue with many of the academic partners in the Caribbean, from Haiti to Jamaica to San Juan, Puerto Rico, to various islands throughout the Caribbean, all focused on how to achieve optimal health outcomes in different settings, different cultural settings, and different challenges with regard to social determinants. And what we want to talk about tonight is how we can use primary care and public health and involvement with the community development, in order to achieve the best possible outcome. The program, as described, has been submitted for continuing medical education and continuing education units for various classifications of professionals. I need to disclose that I have no conflict of interest with regard to financial conflict for this talk. Now, my own training started in the urban public hospital setting of inner city Chicago at Cook County Hospital, but we were introduced there to thinking about different cultural groups and different immigrant groups that we would be caring for, in addition to those who were core to the Chicago population, through messages like this that were embedded in the walls of Cook County Hospital by Louis Pasteur. One doesn't ask of one who suffers, what is your country and what is your religion? One merely says, you suffer, that is enough for me. You belong to me, and I shall help you. And so we were learning about primary care and caring for individuals, often one patient at a time. And it didn't take very long in that setting to realize that there were social complexities and clinical complexities that went way beyond the exam room. I left that setting and went to work in the Farmworker Health Association, based in Apopka, Florida, Central Florida, migrant clinics scattered throughout Central Florida, and again, working with individuals who had clinical complexities, but also social complexities and challenges in meeting their health needs that went way beyond the exam room. Often it was overwhelming, feeling like I was beyond my training, beyond my capacity to meet the health needs, and certainly to achieve optimal health outcomes in our population. The barriers and the challenges were often looming large, and it took me a while longer to realize the resiliency and the strengths that were also inherent in these communities. Let's start with this example. I'll have to think hard to make sure that I say a fictitious name for this patient, because real patients stick with you and you tend to remember their real names. But let's call this woman Guadalupe Benitez and ask the question, what killed Guadalupe Benitez? You already know the end of the story. Guadalupe Benitez was the wife of a farm worker, middle-aged but looked much older. She had worked in the fields herself for many years, but was now no longer able to work in the fields, and just cooked and took care of the home for her husband, who was trying to continue to eke out a living in the orange groves of Central Florida. She had diabetes, poorly controlled. She had a 4th grade education. She didn't read or write very well. She lived in a small trailer with her husband on the backside of an orange grove 3 miles from the nearest paved road. And one day she was boiling hot water on the stove to take a hot bath. And she was carrying that hot water to the bathtub and spilled it on her leg and burned her leg. Created a terrible burn on her leg and wasn't able to come to the doctor right away. Excuse me. She tried some herbal remedies, tried some salves, tried some ointments that she had from her own background. Ultimately started running a fever, had a high level of infection in the leg, and came to see us in the clinic. Her blood sugars were out of control, the leg was horribly infected, and she decided that she couldn't go to the hospital because she already had one bill from that hospital. They had sent her to a collection agency, and now she was afraid that they would take away their trailer if she racked up any more financial obligations with that hospital. She was admitted to the hospital. I saw her in the morning and I saw her in the evening. Got a surgical consult. The surgeon wanted to build up his practice in vascular medicine, so he did an angiogram and he changed the antibiotic to gentamicin, combination of which shut her kidneys down. So then she went on peritoneal dialysis. He tried to do a vascular bypass procedure and had to convert it to an amputation. And about this point in the process, a 4'11" woman, 200-something pounds, blood sugars in the 300-400 range, roaring infection, leg amputated above the knee, spoke only Spanish and had a 4th grade education. And the social worker told me she can't qualify for Medicaid because technically she's not disabled. She theoretically could be retrained to do a sedentary job like a receptionist. Well, that's just wrong. And that individual then ultimately died. But I ask my students often, what do you think it was that killed Guadalupe Benitez? So I'll ask you that, and if you want to type in some answers, you're welcome to respond even now. Was it poverty that killed Guadalupe Benitez? Was it our inability to get on top of her diabetes? Was it health literacy? Was it housing and her inability to have hot water for a bath? Was it the financial issues with being uninsured and not being willing to go to the hospital right away? All of these issues, transportation, language, culture, literacy, poverty, choices, all contributed to a horrible outcome for Guadalupe Benitez and for her family. Some years later, I realized that the husband, who had never come to us for medical care, also was suffering from depression. It was one reason this family was so isolated on the backside of this orange grove and didn't have connections to the extended community there in that part of Central Florida. And so the lack of behavioral health care and appropriate diagnosis also contributed. The point is, there is no one answer to what killed Guadalupe Benitez. It's an all of the above kind of answer, a tragic story that has complexity upon complexity. Some of my colleagues in public health ask me often if medical care really matters at all. They'll quote studies that suggest that medical care only accounts for 10% of health status. And they make us in primary care and in medical care and in direct patient care kind of feel like, what are we doing out here? Are we just little kids with our thumb in the dike standing up against all of the overwhelming influence of poverty and health behaviors? But in fact, the data don't necessarily support that. The public health folks will point to graphs like this and suggest that diseases like tuberculosis and cholera were going down and disappearing before antibiotics even came online, before doctors had any reasonable treatment. They'll point to conditions that were really prevalent before 1950. But I would suggest that in the post-epidemiologic transition of the developed world, it's way more complicated than that. And the chronic diseases and the cancers and the kinds of things that inhibit our survival at this point in the development of our societies actually require much more of an all-of-the-above approach than just public health or just health behavior, health promotion. Healthy behaviors are clearly part of the puzzle. People are connected to their motivations and their aspirations. It's not enough just to tell people what to do, but we have to find ways to help them be effective in changing those behaviors that are harmful and increasing the behaviors that are good for them. The World Health Organization focused on social determinants recently with this report, emphasizing the impact of poverty and neighborhood segregation and education and all of the other factors that go into determining health outcomes. But I would suggest that social determinants are not deterministic. They're not inevitable. And in fact, they often include dimensions of the health system, the public health, and the primary health care system. So how do we as primary care practitioners or behavioral health practitioners engage with this complex world of patients who have social complexities and medical complexities and things way beyond the exam room? We can imagine it this way. We can think about it as a person having a certain health potential when they're born or even in the preconception period. Their genetics, their biology, all predetermine to some extent what their highest potential outcome is in terms of health. But then it's filtered through a neighborhood of poverty, or it's filtered through lack of access to safe food and water or healthy food. It's filtered through their health behaviors that they smoke during their teenage years or adult years. And yes, it is filtered through their access to medical care and primary care. And when we do all this filtering, we see the spread of outcomes across different populations that can go from best possible outcome to some fairly dramatically bad outcomes, and a whole continuum that often parallels the socioeconomic spectrum in terms of health disparities. Now, my research colleagues, and I now play in this space as well, often like to search for that one thing, the silver bullet, the how do we fix health disparities? How do we improve health outcomes? How do we hold everything else constant and do one thing that's going to make all the difference? And in point of fact, we've all realized that that doesn't work. Some analyses we did on the American healthcare system and health outcomes in America showed that actually the pathway to success since 1950, since we moved away from all of those infectious diseases as the primary causes of death, shows that the 9 leading causes of death that have actually shown success, that have shown at least a 50% reduction in mortality, were things that required both public health and primary care. They actually involved some research innovation diffused through the dual channels of public health and primary care. So we had the pap smear as an innovation that could discover cervical cancer early. Public health folks got the message out to women about getting screened for cervical cancer. But all day long in primary care practices all over the country, pap smears are done in that setting, not in public health settings particularly. So all of the conditions that met that 50% reduction in mortality, 7 of those 9 conditions actually turned out to be things that required both public health and primary care intervention. There's a list here. I'm not going to go into the details, but this model of triangulating on success led us then to think about, well, how does that affect health disparities? How does that impact on the differential outcomes, the differential experience of these success stories? So for example, we know that stroke deaths have declined over 50% in 1960s, in large part due to reductions in smoking, a public health intervention, identification of high blood pressure through programs in churches, blood pressure is the silent killer, but also all day long in primary care clinics all over the country, hypertension is the #1 diagnosis. So all of you who are involved in treating high blood pressure in underserved settings and think, wow, you're just a finger in the dike all day long, all you do is treat it over and over again, that's actually part of what has made for a tremendous reduction in premature death and disability due to stroke in this country. And you're a continuing part of that story. Specifically in community health centers, underserved settings, the work you do in primary care all day long makes a measurable impact on things like uninsured emergency room visits, as we've demonstrated in Georgia. Services that are preventive services, aspirin advice, smoking advice, colorectal cancer screening, flu shots, breast cancer screening. If we did those 5 things consistently to a 90% level, we could save over 100,000 lives a year in this country. Now the problem is the benefits of these breakthroughs, the benefits of these innovations aren't diffusing equally to all segments of the population. In fact, we have significant disparities that have been very resistant to these kind of targeted single dimension interventions that people have tried in order to improve outcomes. And so every week across the country, 100 U.S. babies die who would not have died if there was no black-white difference in infant death rates. Put a different way, we could save 100 babies' lives every week in America if we could eliminate that disparity. So how are we going to do that? Dr. Thatcher and I and others wrote a paper not too long ago called What If We Were Equal?, showing that 83,000 deaths a year are attributable to that black-white gap. And this curve, you can see, is a very flat curve from 1960 to 2000. Almost no difference in the rate ratios, the odds of an African-American individual dying compared to a white individual of the same age. Now we may say it's all about the poverty or it's about health behaviors, but let's own our part of that in the health arena. Because during the same time, income dramatically changed, especially from 1960 to 1980. The percent of income earned by an African-American woman compared to a white woman, for example, is represented in this red curve. And we see that there was dramatic change in the socioeconomic determinants, even as the health determinants did not improve significantly. So the bad news is there are a significant number of excess person years lost due to premature deaths every year. In our counties of Atlanta, Fulton, and DeKalb counties, 40,000 excess person years every year. But there are some green counties here too, with no disparities. And it shows us that disparities are not inevitable. There must be a way to make a difference and to reverse these inequalities. And I believe that primary care folks, behavioral health folks, individuals involved as clinicians in underserved settings can be the catalyst, can be the champions for making this difference. But we can't do it all by ourselves. The lower mortality versus health equity issue is shown here in these graphs on cervical cancer. And with pap smears, we saw dramatic reductions in both black and white mortality. But here's a very different example. When HIV therapy became more effective in 1996 with the introduction of protease inhibitors, death rates were going up all over the country. And black rates were higher than white rates, and death rates were going up in an epidemic proportion. 1996, one of the most dramatic reversals of an epidemic in our history, those death rates started coming down dramatically, largely due to the diffusion of a new innovation. But that innovation did not diffuse equally across all segments of the population. What we saw was once life-saving treatments were available, they were not equally available to all segments of the population. We've shown even with exactly the same Medicaid card in the same state with the same drug formulary and the same provider network, African Americans are less likely to get the effective antiretroviral therapy than are white. And we can see the same across socioeconomic gradients as well. So disparities persist, and clinicians stand in the gap trying to make a difference in that. The diffusion of innovation is not one curve, but a curve that is much different for underserved segments of the population and disenfranchised populations. As a result, what we see is that those very conditions in which we're improving outcomes for the U.S. population, where we have effective innovation and we have effective ways of delivering them through public health and primary care channels, those are the very conditions in which disparities are starting to widen. As we saw with no breast cancer disparities in mortality earlier in the century, suddenly developing black-white disparities as a result of the availability of effective screening tests, effective diagnosis, and effective treatment. But those effective treatments not uptake, the uptake was not equal across all segments of the population. So we see that social determinants, poverty, education, all the other factors related to neighborhood level context are one of the other filters through which we have to understand how innovation gets through the public health channel and through the primary care channel to individuals. And it also suggests that working in community development, economic development, community organizing, and other ways of affecting social determinants, education, can perhaps be one of the additional legs of a three-legged stool that's required if we're ever going to get to optimal and equitable health outcomes. So let me stop with that for just a moment, and I'll go back to that slide and just see if there are any questions from our audience. And I'm going to take a sip of water, and Sabrina, if there are individuals who are asking questions. Very good. Well, let's continue then, and we'll look forward if there are other questions as they come in. I know we had some technical glitches tonight in getting people signed on, and so this will be available as an archived webinar in future, within a few weeks. Well, here's one of our challenges in making that integrated social determinants, public health, primary care. How do we do them all at the same time? The challenge is that those of us who trained in public health stay in our little silo, and those of us who trained in primary care stay in our little silo, and those of us in behavioral health are in our little silo, oral health in our little silo, and people doing community development work or economic development work or community organizing, we all may be working in exactly the same neighborhood with exactly the same clients, and yet not working together, not combining our efforts in a blended or integrated approach. And so we have all these different silos beyond the health sector, payers and funders and legislators and business leaders and faith leaders, all of whom could potentially be part of the solution. Many of us in primary care live in a tiny little silo called the exam room. And we run from one exam room to the next exam room to the next exam room all day long seeing our patients in a model of primary care that I think most of us are agreeing needs to change somewhat if we're going to truly affect the health outcomes of our patient panel. Point of fact, most of our patients don't live in those exam rooms. They're free-range humans. They live in families and communities. They wander the countryside doing all kinds of health behaviors and living in contexts that are both strengths and sometimes health risks for them. And often they have to manage their own care and their own outcomes. I'll give you an example of building a bridge between primary care and community care, health promotion in the community setting or self-management in the community setting. In farm worker clinics where I used to work, we would have a diabetic patient who eats at irregular hours and has episodes of hypoglycemia. And a traditional diabetes educator might sit with them and say, well, you need to eat your meals at the same time every day, and you need to take your medicine at the same time every day and get about the same amount of exercise every day, and then this will become much more predictable. And they didn't know that that farm worker was going to get on a truck and drive 13 hours to South Carolina or Ohio and pick yams all day long tomorrow on a 12, 13-hour day with a coyote crew chief who would give this individual absolutely no control over what time they ate or what time they went to the bathroom. And so the only way we learned that we could help those individuals was to have a diabetic promotora, a diabetic community health worker, a peer counselor, someone who themselves had diabetes but also knew the farm worker lifestyle and knew these individuals and could communicate relationally, not just intellectually. Not just transferring content, but transferring trust and helping the individual to figure out together how to overcome those episodes of hypoglycemia. Here's an example of why we might need altogether solutions. If you think about obesity and the epidemic of childhood obesity in this country and all the complications from it, think about it this way. To prevent obesity and its complications, all we have to do is modify a child's health beliefs and attitudes, exercise and eating, self-esteem, resiliency, coping skills, and sense of hope, and improve their neighborhood walkability, parks, playgrounds, grocery stores, and fresh produce while we downsize their mini-marts and fast food restaurants. And restore PE and recess and healthy cafeteria menus and get rid of vending machines from their schools, and provide access to a primary care health home with an integrated primary care behavioral health team, engage in preventive anticipatory counseling, motivational interviewing, and brief behavioral interventions, all in the context of his or her family and social relationships. Who's up for that? Who wants to do that all by themselves? This is clearly going to have to be a team sport if we're going to have any impact on outcomes related to childhood obesity as a behavior and as a health outcome. So we can't separate below-the-neck obesity from above-the-neck motivations and attitudes and emotions. We have to engage behavioral health, not just as mental health or substance abuse, but as behavioral health in terms of human behavior and motivating change and understanding how that works, because it's more than just about teaching what's right to eat or how much exercise to get in a day. And we can't separate the issue of healthy kids from creating healthy communities. A healthy community has people out and about. There's a sense of safety. There's a sense of community and connectedness and resiliency and hope. That's a safe, healthy community. An unhealthy community has unsafe, insecure settings, fragmented, economically depressed, maybe drug infested, maybe despairing, maybe hopeless, maybe jobless. There's a difference in those two communities, and all of those things are going to impact how effective we are in improving outcomes, whether they're obesity outcomes or diabetes outcomes or any other kind of health outcome. We try to separate a school's educational mission from its health issues. So we talk about PE and recess and vending machines and school-based clinics, but then we act as if, and the rest of the time just go on teaching like you always teach. Leave kids lined up in chairs in rows, sitting down, listening passively to a teacher. If that's the way you teach, that's a 1950s model. If we're going to think about childhood obesity and activity, maybe we need to think about active learning and stand-up learning, where kids are not in chairs most of the day, where they're actually doing things most of the day. What we know from educational research is they learn better, and what we know from health research is they also don't gain as much weight when we do it that way. Synergies, that's what we're looking for. Working together, partnership, teamwork. We all can triangulate interventions. I'm going to kind of move through an example here now as kind of a way to summarize all this in a much more real-world kind of way. It comes from a much less industrialized setting, an area of central Honduras, the state of Olancho, where in the 1960s and 70s, infant mortality rates were quite high, over 100 per thousand. That's over 10%. Even as late as 1980, the rates were as high as 70 per thousand. And that was true also in the Agalta Valley of the state of Olancho, about 70 per thousand, or 7% infant mortality rate. But since 2006, in 27 villages where there had been infant deaths up until that time, there have been 0 infant deaths in the 27 villages covered by the comprehensive community development work. It happens to be an organization called Honduras Outreach. But I want to use them as an example to ask the question, just as we asked what killed Guadalupe Benitez, I want to look at pathways towards success. Rather than focusing on the disparities and the bad outcomes and the tragedies that we've all seen, what would be the path to success in the communities in which we work? In the Agalto Valley in Honduras, how did they improve those infant mortality rates and improve many other clinical outcomes? Was it social determinants? Was it all about the poverty? They do agricultural development. They do economic development. They do vocational training. This individual, by the way, at the bandsaw, is also in a wheelchair and has developed a very viable business in that community. Is it pre-K and kindergarten education? Is it communities organizing and coming together to decide on how to make their health better? So was it social determinant that improved the health outcomes in the Agalto Valley? Or was it safe water to households and traditional public health sanitation kinds of measures, laying water pipes to bring safe water to every household, to dig latrines and to have septic systems in place for waste disposal to make sure that the water wasn't contaminated, putting chimneys inside homes to eliminate indoor smoke from indoor kitchen fires, to decrease the asthma rates among kids. Chagas disease is an issue in that area, and so replacing thatched roofs where the flies that cause Chagas disease live with other kinds of roofing materials. Promotores going around and teaching about malaria prevention and eliminating stagnant standing water. Was that how these improvements came? Traditional public health and sanitation approaches. Was it health literacy and nutrition? There's an intensive center there for mother-child malnutrition when they have cases of kwashiorkor and marasmus, and nutrition education programs, they have school-based meals, and nutrition education not just for the adults but for the kids in the school. Was that how they made the difference in the Agalto Valley of Olancho, Honduras? Or was it primary care and prenatal care, the satellite clinic, nurse auxiliaries, the promotores, the dispensaries, a family practice physician, Dr. Herman Jimenez, who's very dedicated and is available in a clinic but also goes around training the nurse auxiliaries, training the promotores, and teaching in the villages as well as seeing patients in the clinic, doing prenatal ultrasound tests and referring to more advanced care for complex pregnancies and advanced pediatric care as well. Was that what saved the babies? Was that what improved the health outcomes in the Agalto Valley? I bet you know what my answer is by now. It's an all of the above answer. It took all of these things, a comprehensive, integrated approach, public health sanitation, water pipes, latrines, teaching about malaria, education, nutrition. Yes, primary care makes a difference too, and the prenatal care as well. And the economic development, communities organizing and identifying their own strengths in order to be able to change the outcomes that they've seen for decades in their own communities. It's an all of the above answer. Nobody could have done it by themselves. It took a lot of teamwork, a lot of partnering, but clinicians were a catalyst for making it happen. Clinicians were measuring the outcomes, and clinicians were identifying the leverage points where active work could make a difference in that community. So somehow, we as clinicians need to, every now and then, poke our heads up above the exam room and see the bigger picture. Say, how can I be a catalyst? Not to do it all by myself, but how can I be a catalyst for the primary care patient-centered medical home and also become a home base for community health workers, promotoras, outreach into the community, community-based health education. How can we do jobs training? How can we do community organizing through our community governing boards? How can we do economic and social development? And if we don't know how to do it, with whom can we partner to make this happen? All of these steps are going to be necessary if we're going to break through the health disparities, the unequal health outcomes that we've allowed to persist in this country for decades, but which are not inevitable. The trick is none of us can do it by ourselves. It's a team sport. One more example before I close. In Dane County, Wisconsin, the infant mortality rate was high. Black infant mortality rate was twice that of white. Very premature births were at least twice as high among blacks as whites. That had been true for decades. It was true in every other metropolitan area of Wisconsin. And all of a sudden in 1990 to 2000, up to 2006, those African American infant mortality rates started to drop precipitously. Very low birth weight rates began to drop precipitously. And if you want to Google a New York Times article on Dane County, Wisconsin infant mortality, what you'll find is that there was no one single silver bullet program that made it happen. No public health director can stand up and say it was my program, we implemented it, and look how great we did. In fact, the interviews with the public health program director point to all the other parts of the success. Clinical certified nurse midwives at a community health center giving relationally based prenatal care was an essential part of the strategy. Public health nurses doing outreach and education, an essential part of the strategy. A health law group helping women with issues of housing and domestic violence, counseling and behavioral health, wraparound services, transportation. All of those concrete services were essential components of making this work. And then they also point to one other factor, and that is that they engaged the faith community. And somehow they were able to convince women who were pregnant in Madison, Wisconsin, that they would be wrapped up in love and support from the moment they knew they were pregnant to the time that baby was born. The babies would be wrapped up in love and support and know that they were entering into a much larger family, a community-wide effort to make sure they grow up healthy and strong and able to contribute to a strong and resilient community. It's an all of the above answer, and no one person can take credit for it. The good news in that is no one person can take responsibility for it all. You don't have to take this all on your own shoulders, but you do need to be the catalyst, maybe a champion, and an outreach partnership builder to help these teams begin to form and to make good things happen in your community. Each year now they save at least 29 babies who would have died if they hadn't addressed the black-white infant mortality gap. All of us have the ability to contribute to those kind of success stories. So we have to be humble about it. None of us trying to do it by ourselves. No Lone Ranger work. No superheroes trying to do it all by themselves. We're all in this together. In effect, all as angels with just one wing, and we can only fly when we embrace each other. Thanks for being part of this webinar tonight. Do we have a question, Sabrina?
Yes.
Sabrina's right behind me, so if I turn around like that, you'll know why.
I'm going to have to yell now because it's getting kind of loud out here. But I did want to just ask you, since at the beginning we did mention that we were here at the Triangulating conference.
Yes, sir.
Could you say a little bit to our audience about what the conference is? And
yes.
Maybe give an overview of what the sessions will be tomorrow, and then what you hope to achieve by us being here in Puerto Rico.
Well, and I hope we can do one of these in several places around the country in coming years. But the idea was to look for the success stories. We all can point to tragedies and disparities and inequalities, but often the path to a cure is, the cure is not always the inverse of the cause. We're looking for the path to success. Folks who have actually improved health outcomes, folks who have achieved health equality, or at least moved inequalities to a point of greater equity. And so we've asked folks to come from all over the Caribbean, as well as from Miami and New York and other academic institutions and community-based organizations working with Caribbean populations and the Caribbean diaspora, if you will, starting with that group of people and that region of the world, we're looking for those stories of programs that integrate community development, boots on the ground, working to make communities stronger economically and educationally and in terms of their organization, with public health approaches and sanitation and health promotion and risk reduction, with primary care, with the medical component, where these are all tied together and working with each other. And behavioral health components as well will be represented. And so we're going to be hearing best practices ranging from Haiti, the Zanmi Lasante Partners in Health program that Paul Farmer and others have been building over the past decades to improve health outcomes in Haiti through this balanced, integrated model. We're going to be hearing stories from Caribbean community networks in New York City, from folks in Miami working with Caribbean populations there, and islands ranging from Jamaica to the Turks and Caicos to Haiti to Puerto Rico and beyond. We're going to be learning from the best practice examples, and we hope many of you will submit to us and tell us about primary care, public health, community development, integrated, blended models that we can tell the story about. And perhaps on our website we can celebrate more of these best practices the more we learn about them. Any additional questions? Or?
No, there are no more additional questions.
All right.
So thank you, Dr. Russ. Thank you also to our audience for your participation and your attendance tonight. I would also be remiss tonight to leave tonight without saying thank you to our very fine IT department, Jerry and Hugh and James and Brian. Thank you again for all that you do. An evaluation for this webinar should pop up in another window if you're using Internet Explorer and another tab if you're using Firefox. Please join us tomorrow as we will be streaming live from the Triangulating conference. The session should begin at 8:30. Feel free to check the website for a schedule of all of the events tomorrow as well as Friday. This webinar tonight has been made possible tonight through our partnership. I also like to say that direct financial support has come from a cooperative agreement with the U.S. Department of Health and Human Services. The series is made possible through the partnership with the National Center for Primary Care, the Association of Clinicians for the Underserved, the National Healthcare for the Homeless Council, and the Migrant Clinicians Network. Thank you again, ladies and gentlemen, and have a great evening.
Okay, we're out.